So I'm going to chair and talk in session one. So session one is really focusing on the early work that was done, the evidence review, which I was involved with quite heavily, and then some work on cohort studies where we've been looking at existing data and existing instruments and it's all about just setting the scene in terms of setting the scene. I feel really intimidated, so I just need to remind you that I'm a PhD in soil science, so I'm definitely...
And a PhD.
Yeah, well, that's also. So, be kind. Okay, so session one, and we're not... The idea is to give key findings, and because, you know, we all know systematic reviews, you work your way down, you go through. So the thing that impressed me about these systematic reviews is we worked with Quokka, and Brendan, I think, is a sole Quokka.
The only one.
Rep here today. They were really comprehensive. In fact, the first one started with 50,000. I thought, what? Anyhow, an amazing team in Oxford who are in the UK. Joseph wasn't in Oxford at the time. Is he in Oxford now? Yeah. And he's just amazing going through all these, and they're actually all double screened, believe it or not. So without further ado, there were four reviews. As I said, they were all really comprehensive, difficult reviews. I've highlighted the three that we did with Quokka, and that was really great exercise working with Quokka. And I think it just shows that, you know, we all had the same motivations and drive. What was the point in working separately? So the early ones, the first one is the first one is just what's out there in terms of generic instruments. Then we delved in a lot of detail into the psychometric performance of the ones aimed at generating value sets. Then we did another couple with Quokka, looking at the methods for eliciting values in children's health-related evaluations, and also the one that Joe just mentioned with relative social value of child and adult health. Setting the scene. So this one here was what instruments are out there, how do they perform, and basically the first review showed, well, there's lots. So these are just generic measures. In all there was 110, and 17 of those are designed to have value sets. So by that we mean they're put onto the utility scale, the 0 to 1, so we can calculate QALYS, which are the backbone of cost utility analyses. Lots of different conceptual basis behind them. A lot of the ones that we would call quality of life, health-related quality of life, really come under the first one there, which is functioning, disability and health. It's really more about how people function in different settings rather than how they feel about it. And lots of domains. We know that, so some instruments cover, like the EQ5D, five domains, and then others have CHU9 S9 and so on. Lots of different domains. So a bit of and variation across age groups. I'll get to the summary in a sec. So moving on then, so as of October 2020, there were 17 generic measures designed to have value sets, but only 11 had value sets. So these are the ones that a health economist would be looking for so that they can do the economic evaluations to calculate QALYS. So there are lots out there, but the problem is they cover different and varying age groups. There isn't one that covers all ages. When I'm saying age groups, I mean kids, so less than 18. Different constructs, so different contents. Very few for less than 5-year-olds, well, few for less than 5-year-olds, and virtually none for less than 2-year-olds. Really variable evidence of validity, reliability, responsiveness. And then when you look at the value sets, they're highly variable by that, and I'll just show you a quick graph in a moment. And even for one single instrument, the value sets might vary, which means that if you use one value set, you'll get a different quality than if you use another value set. So this is just, I don't want you to look at it too much, other than to show that this was looking at psychometric properties of a range of instruments. It's just to show that there's some instruments for which there's virtually no quality evidence under fairly important criteria such as responsiveness. Can you track the changes with time? So a bit of a dog's breakfast, if you like, of evidence when it comes to the way the instruments perform. And this is from the first review, just showing what I was mentioning in terms of value sets. So what we've got here is this is just for CHE9D, which is one instrument, and looking at the distribution of the values. So 1 is full health, 0 is equivalent to dead, and minus means worse than dead. And that's just one instrument, and you can see it that depending on who valued it, how they valued it, we're getting quite different distributions, which has implications with respect to calculating QALYS. Valuing health sets. So with this was where we said, what evidence is there about what's the best way to do it? Do different methods give different results? Again, this is a Quokka review, joint review. And I guess the takeaway message from this one really was there's not good evidence out there, and there's not good evidence out there because often it's badly reported. But what we have seen, this graph is showing here are the different methods with time, and what we have seen is a trend to using the methods of DCE and best worst. So you're going to hear a lot about DCEs and best worst today. So their methods, I guess loosely called indirect methods of valuing, and there's been a trend to them being used a lot more than the more traditional ones, the time trade-off and standard gamble. So this is just a summary of all that. As I said, there's very little comparison of methods. This trend towards increasing DC use of the choice methods, preference methods, my view is that it's based on the perception that they're easier, but when you go look for the evidence, there isn't any. And they probably are easier to do than a time trade-off. They're possibly less problematic for ethics because in a time trade-off, you're trading against dying, death, and that's perhaps seen as not such a great thing to put in front of kids. So a DCE isn't asking you to do that. It's looking at two conditions alive and saying which one's better. There's some evidence that, and we're going to, Joe Coase is going to talk about difficulty of kids doing these DCEs and best worst. There's some evidence there that suggests the best worst is a bit easier, but not always, and it depends a bit on the complexity. So EQ5D is a simpler instrument. CHU9D has more domains, and so it's harder to make comparison. Perspective. Well, it all depends on who you ask and how you ask them. So you ask an adult to look at a health state and say, what do you think about that for yourself? Or you might say, what do you think about that for a hypothetical child? Or what do you think about that for your child? And you'll get different results. Adults don't like to trade life with kids. So utilities end up being higher when they're valued by adults because they don't like the idea of trading life with kids, so you get high utilities. I think I've just said both of those. So the high utilities, also when you compare the adult versus the child, so if the child values it, the utilities tend to be lower. But it's not possible to disentangle it all. It's just such a mess of studies, approaches, poor reporting, because these are lots of studies. So this was a nice spin-off paper that we did from this. Again, a joint exercise where we said, well, look, reporting's got to be better. So we generated a checklist to help do that, and that's been published in Pharmacoeconomics. The last one, social value. So this is all about so social value. You know, what is good for society was our working definition. So we looked for basically any study type that was assessing the value of health for an adult versus health for a child, any age group. We did include some qualitative studies as well, but there's willingness to pay, DCE, so discrete choice experiment, opinion surveys, and equivalence questions, which is trading off people or trading off the health gains. Lots of studies again, and what, I don't want you to look at this too much. I always say just go out of focus is probably the best. I'm actually quite proud of these figures because we were trying to capture in the one figure everything. But basically what it's showing, and this is just for DCEs, we've got age along here, that's 18, and it's just showing all the studies. Some of them looked at different age groups, which is where we've got an arrow. Some of them looked at specific age groups. And a red means there was a preference, so a greater value put on that. And you can see it's not always kids, and it's not always the little kids. It varies, so if you just ask the question, should the values for age groups be the same? Based on this evidence and all the other evidence, on balance, you'd say no, but it depends who you ask, what you ask them. So if you ask them about vaccination for flu and look at the values of different age groups, in fact the elderly would be preferred because they're seen as vulnerable. So the greater value put on the elderly in that case. So what you ask, how you ask it, and the perspective. So my other feeling about it is, if there's a weight there, or firstly it's not clear, but it doesn't look to be big. But then we're going to explore that later. So the key findings before moving on. There are many instruments out there that could support cost utility evaluations and therefore health technology assessments, but psychometric properties are often variable and lacking. They have varying constructs across age groups. They're limited measures for young kids. Reporting is poor, so we don't really know how we can rely on them. On balance, does appear, it makes sense, I guess. There's a social value placed on children and young people, but it does depend on the context of what you're asking and how you're asking them. And if there is a weight, then it's probably fairly small. If you wanted to say, right, we're going to put a weight on it, the evidence would suggest it should be fairly small. Now, I'm just being the chair, keeping an eye on time. So that's a whirlwind of the systematic reviews. As I said, they're probably the most satisfying ones I've ever done. I've done them quite a lot because they were difficult, because they were addressing difficult questions, and I think because they've pulled together a lot of research and hopefully helped to provide direction and get away from this sort of piecemeal, often do what you think is a good idea. I don't know, we've probably got time just for questions, but also happy to take them as we go along or at the end of this sessions. So if there are any burning questions, clarifications. Good, because otherwise we will move on. Oh yes.
Just two questions. First one, the social value in the analysis that you did, there were no, you said that it varied by a range of factors. Was there no pattern in terms of how those factors varied? Was there, were there any elements that suggested that you got less of a social value weighted to these sort of characteristics, presence or the opposite?
I think the thing that's bad. What stands out is if you ask generic questions about health, then invariably there will be a value or a weight given to children. When you ask about specific conditions, then it's going to very much depend on the condition. So the example of the flu was still about valuing health, but it was about a specific condition, and in that case it was the elderly, even older than me, were the ones who were prioritised and a weight put on it. So I think, and then there is some suggestion, and Emily's done work in this, and it's part of the torch as well, about not just quality of life, but length of life, and the type of, well, I'll explain it better than me later, but the type of, anyhow, it's, I don't think that's the only thing that stood out to me. A little bit of difference with the methods, in that when the opinion surveys tended not to show the same level of weighting. But I think that's, when you think of willingness to pay, DCEs and so on, it's a little bit abstract what you're doing. You don't necessarily, we talk about, it's all about trading off, but you don't actually know you're doing that. And you don't know what it's going to end up with. So it's sort of tricky for people in a way. So it doesn't surprise me that's, and the qualitative, because qualitative is very much, you get the full gamut. So there are, and what's interesting about qualitative is when somebody says, I'm not going to favour them, you understand why. So I think one of the reasons is, it's too hard a question. We're assuming policymakers and guideline people will sort that out for us. So,
Can I just have one comment on what Martin has said there? Some of the studies focus specifically on how the value you place on child instead of healthy individuals very varied. But other studies looked at they will also vary in terms of whether they just focus specifically on age or age in conjunction with other distribution factors, as they became quite difficult to generalize.
Mark, just ask a follow-up question. So, if the kind of the direct elicitation tasks, I guess, for what thanks, Kim, sorry. So those direct questions, the kind of survey type direct questions, so not DCS, investors, and trade-off and stuff. How much of that the fact that those came out with no preference weighting, how much of that is driven by the fact that maybe when you're asking people directly, they actually don't want to say, rather than there not being a preference, but it's actually more that they think that interviewers, like that they don't want to necessarily explicitly declare their preferences.
Yeah. Oh, I think that's definitely part of it. But I think it shows that different methods give different things, but it stood out. So I think there's obviously something going on there. I think qualitative and the other quantitative methods show that people do place a value. So yeah, and I think also those surveys, they probably vary in quality and what they're asking.